All right, and that is the subject of discussion today. Welcome to the show. This is My Doctor. My name is Winnie Lubembe. Always a pleasure to have you on board. And from the video today, our focus is on hemophilia. And I'm pretty sure you've seen one or two or even three people with the same condition, but most of the time we might not really know that's actually a condition. Sometimes people say that this person is pretending to be bleeding too much, but what we don't know is this is a condition that affects so many people because according to the U.S. Centers for Disease Control and Prevention, the hemophilia occurs in approximately 1 in 5,000 live births. So again, what is it all about, and what are some of the treatment options for the same? Well, you want to stick around till the end of the show to understand that and much more about hemophilia. But if you have any other question or a comment, or probably you are living with a condition and want to ask the doctor any of the questions as far as hemophilia is concerned, then you know the drill by now. Feel free to engage with us on our SMS line, that is 40920. We look forward to hear from you as far as hemophilia is concerned. So welcome again on board. My name is Winnie Lubembe, and our guest is already here, ready to answer all your questions, but most importantly, give us all the insight we need to have as far as hemophilia is concerned. So, Dr. Njenga, long time no see. How have you been?
I'm good.
You've been well?
Yes.
Welcome to the show.
Thank you so much.
It's so good to see you after a long time.
Yes.
You know, and we were discussing, do we start with Happy New Year, Happy Birthday, Happy Anniversary, Happy everything?
All of them.
All of the above.
Combined, yes.
But it's good to see you.
Good to see you too.
Welcome to the show. And just in case someone is tuning in today for the very first time and thinking, okay, so who's the doctor that we have on set today? Could you say hi to our viewers?
Hi viewers, my name is Dr. Jenga. I'm a general practitioner in private practice, I mean.
Okay.
You're welcome, thank you.
All right,
Yes.
and of course you're welcome as well, Doc. Now let's just start, because from the video we saw, basically about how the blood functions and the veins and arteries and all those things. But then again, when we talk about clotting, some of us know clotting on the one that is fatal. And some people just understand the normal clotting, and some people don't really understand what usually happens, especially when there's a cut, and all those things. So when it comes to clotting, can we just understand, first of all, clotting and why it's important? So we can just start with clotting in general. What is it? What happens? And then why is it so important?
Okay, thank you so much, very much, Winnie. Clotting is not a strange term.
Okay.
Everybody is aware of clotting, but some could not know what clotting is all about,
yeah.
and what happens to bring about a clot. So what is a clot? What is clotting? Clotting basically is the process that takes place when you have damage or injury to your veins, to your arteries, and to your tissues. When you get an injury, for example, a cut or a bruise, there tends to leak some blood. Blood comes out. And this blood is supposed to be in the vein. So this blood, if it is not in the vein, will go to the wrong place. Maybe it can go to the tissues or the cells. So when there is a leak or a cut or a discontinuation of the vein, what happens, you have some cells in your blood we call platelets.
Okay.
We are aware we have many components of blood, the red blood cells, the white blood cells, the platelets.
Yeah.
And the platelets are usually basically the ones that are involved in the clotting process. So when you have a cut, what happens? Protein pull together and come to the site of the cut, and they pull together and they form a mesh together with other proteins, which we call clotting factors. They come in place, they form kind of a wire mesh fibrin-like, so that they seal off that discontinuation or cut, and that process brings about clotting.
Clotting, okay.
Yes.
And then is it dependent? Because you see, most of the time, sometimes we see that, and especially when it's like a minor cut, clotting will occur in almost a few minutes, and then somebody is okay.
Yeah.
But then again, in terms of when there's like a deep cut, and especially the ones that involves the vein, does the same process really occur?
It does.
It does occur.
It does.
Okay.
What happens, maybe it takes long because of maybe the extension, the
yeah.
extent of the cut
Yeah.
or the wound, or whatever has happened. But the process is still the same,
Okay.
more or less the same. There is nothing that changes, only that when a big cut is there, there is much pulling of the platelets, and there is also much pulling of the clotting factors. Yes.
So it takes a bit of time, and some people might require a few stitches here and there
Exactly.
to ensure that then there's no discontinuation
Exactly.
of blood flow.
So you enhance clothing. You also come and enhance
and enhanced
clothing.
clothing.
Yeah.
I like that, you
Yeah.
enhance clothing.
Yes.
Okay, and then again, so what about the one that happens internally and again might be fatal? Is it the same concept where probably proteins again come together, form a mesh, and then the blood is not able to flow correctly and then ends up, causing a blockage or something like that?
It is still the same.
Okay.
The cascade that is being used by the body is still the same. Only that here we are talking about internal, maybe internally, like in the brain, where you see the brain is much fatal because you can have a lot of bleeding
Yeah.
will have occurred before the clot is formed. And also you see the clot itself might even dislodge from the site
Yeah.
and then go and block
Yeah.
or block the vein, and then you get other complications like stroke
Yeah.
and so on and so forth.
Yeah, because I was reading somewhere they were saying sometimes and especially the one that dislodges, it can
Yeah.
find itself in the heart.
In the heart,
and
in the
then,
lungs.
Yes.
Yeah.
And then causes a bit of chaos there.
Exactly.
And which can be fatal, and especially
Very
if nothing
fatal.
is
Very
done.
fatal.
Okay then, but again, because now remember we talked about the aspect of, I mean, for the minor injuries or cuts,
Yeah.
it can just form a clot naturally and
Yeah.
then that's it. But for this other one, where especially when it's deep, again, probably some might have to go through a stitch here and there,
or
which,
repair.
like you said,
Yeah.
or repair.
Yeah.
But then again, so the one that happens, let's say, inside the brain, for instance, do we know sometimes what causes those types of clotting, or even just internally, do we know what causes those types of clot? Because we can't say that the vein was somehow cut, it's internal.
Yeah.
Yeah.
Sometimes, like in the cases of the brain, we have various causes or etiologies. Like, for instance, when somebody has a high blood pressure, and sometimes we discussed, I don't know whether it's in this forum, that one of the complications of high blood pressure is that it can make the arteries that are found in the brain to rupture.
Yeah.
And when they rupture, then you will have hemorrhage.
Yeah.
But also, it could be mild rupture, causing mild hemorrhage, and then the clot forms.
Yeah.
But you see, there are sometimes people get extensive rupture, causing extensive hemorrhage, and leading to fatal complications, including deaths. So those are some of the causes, including blunt injuries. Somebody
yeah.
has had an accident, and they just say, I have not been cut anywhere, I'm just okay.
Yeah.
Then later you find out somebody had internal hemorrhage or internal bleeding.
Yeah.
Yeah.
And we'll discuss that, of course, during the process, during the discussion on hemophilia. But now that we have a better understanding about clotting and how it works,
Yes.
and again, dependent on the cut or the bruise, it could be faster or it could take a bit of time and might need, like you said, assisted
Yes.
clotting. So then hemophilia, what is it and what happens, especially to a person who has hemophilia?
Thank you so much. So hemophilia now, we want to define what is hemophilia, because we now have seen the normal clotting
And
process.
why it's important, yeah.
So hemophilia is basically a genetic, basically we'll call it an inherited genetic bleeding disorder,
Okay.
whereby you lack or you have less clotting factors. That is how I would define it. That it is a inherited genetic blood bleeding disorder, whereby you lack or you have less clotting factors.
Yeah.
And I have said one of the some of the cells that are involved in clotting are platelets. But apart from platelets, you need some other factors, some other special proteins we call clotting factors, which are 13 in number.
Oh, okay.
Factor number 1 to factor number
13. Okay.
And they are named not the way we write one. You see the one we used to write 1I.
Yes.
That is Roman.
Yeah. Yeah, the Roman
abbreviation.
Style. Yes.
So that is actually the factors we are dealing with here when we are talking about hemophilia.
Okay.
Somebody has less or
none. Okay.
Yes.
Of the same. Now, so here comes the question. Talking about genetics, right? And the fact that you talked about an aspect of, again, the protein, which are very important in helping, the clotting process. How common is it? Or how prevalent is it? Because, when we were discussing and we were like, hemophilia, like, what is it? Like it's a condition that we don't hear a lot.
Yeah, exactly.
Yeah, so we had to read through to get to understand what it's all about. But then again, so how common is it? Especially, let's say, in the country, or do you encounter this on a almost day-to-day basis?
No. It's
very rare
condition.
Okay.
And if you find it, as you've said, it's 1 into 5,000.
5,000 live births, yeah.
Yeah. If it's 1 into 5,000 live births, you see, even you can miss it.
Yeah.
You basically will miss it. And especially if there is poor diagnosis, you will definitely miss it.
Okay.
Somebody will be managed for other things. Kumbe, it was hemophilia.
Hemophilia, yeah. And I think the fact that it's rare and we don't see it often, and like you rightly put, it's very easy for misdiagnosis.
Yeah.
Or number 2, think that this is something else,
something else.
And then we don't take it seriously, but
Exactly.
like you said, this could be fatal.
Yeah.
Especially if it's not treated or identified on time.
Yeah.
So genetics. So does it mean that if, let's say, a member in my family has it, does it mean that, and especially for the parents, right? So is it one or both parents must have the condition for the child or the children to have it, or mostly even if it's one parent, a child could have it?
Basically, if we are talking about parents, either of them
Okay.
with the condition or the trait or the disorder, if either of them has, she, the mother, or he, the father, will pass the trait to the children.
To the child, yeah.
And we will see that. But most of the time, hemophilia is common in male, not female.
Not female, okay.
Female are most of the time carriers, so they don't exhibit or show symptoms. And if they do, they are mild symptoms.
Okay.
So somebody just say, my blood takes a longer time to clot.
To clot, yeah.
Yeah, you see? But for men, they suffer the condition. And we will explain why they suffer.
Okay.
Yes.
Because then again, yeah, so that aspect of then being a carrier and not exhibiting like the severe symptoms, it could be just mild. Or sometimes people don't even have symptoms at all, right?
At all, yeah.
Is that dangerous for such people, and especially those who do not exhibit symptoms?
No, it's for this one.
Yeah.
It is not dangerous.
It's not.
It's
okay.
not dangerous because we will explain. Because basically, ladies have 2 X chromosomes. So because the gene that causes the defects is usually on the X chromosome, and most of the time, because I've said ladies are carriers, one is the one that has the defect, the one chromosome.
Yeah.
The other X
one...
chromosome does not have.
Okay.
So they have an advantage that this one that is okay actually overrides the one that is abnormal.
Is defected. Okay.
Yeah.
Okay.
Exactly.
All right. But now for the male, it's vice versa.
For the male, it's vice versa because they only have 1 X chromosome, and if it has the defect, then you will have to suffer the condition.
The condition, then pass it on again to the children.
To the children and not to the children. Basically male pass it to their daughters. They don't pass it to their sons.
Okay.
I will explain that cascade.
That's interesting.
Also.
Okay.
Yeah.
Can we understand that? Because
yes.
now, Okay, because now I'm thinking for the male children, you see, they have the same chromosomes as the dad, right?
Yes.
You know, as far as like, so then why pass it to the
Because
to the
male,
lady?
they have the X and Y
And
chromosome.
Y chromosome, true.
But you see, for a girl, she has to get an X chromosome from the mother and an X chromosome from the dad. So if the dad is a sufferer, it's the daughter who will
Who
suffer.
will suffer? Okay.
You get me? It is the dad. If the dad is a sufferer or affected, because the girl will have to receive the X chromosome that is defective from the dad. But you see, for a male, he will receive the Y chromosome that does not have the defect. And the mother is not affected, so the X chromosome of the mother is okay.
Yeah.
So the boy child will not get the condition. So the dads pass to their daughters.
Okay.
But the mothers can pass to daughters
Yeah.
and
to the son as well.
to the sons.
That's interesting.
Yeah.
Okay, because now I'm thinking it's more common in male as compared to
Yes,
female.
yes.
But then again, it's mostly then transferred to the female, like to the child.
To the child
Yeah.
from the affected
From the
dad.
affected dad.
Yeah.
That's very
And you
interesting.
see, for
Okay.
now, for a girl now to suffer hemophilia, most of the time he has to acquire the X chromosome that has the defect from the dad, and also another X chromosome that has the defect from the mother, which is very rare.
Okay.
That is why
That explains why then.
you get now.
Yeah.
So that's why they are carriers.
Yeah.
Because most of the time, with the genetics of pairing up, the chances, probability, you know, most of the time, the girl will get one chromosome from the mother, the other one from the dad.
From the dad, yeah.
Yes.
Okay.
So for them to be hemophilic, they have to get both. From both parents.
Okay, which are defected, that is when then they'll have
Which is
the
very
condition.
rare.
Very rare.
Yeah.
I like that. Okay then. So because we have like different types of the same, and like you said, there are 13, again, factors that, again, form the same. But in terms of the two, is it 2 or 3 that are most, two that are most common?
But we mentioned 3.
Yeah,
yes.
we can do 3. Yeah. 10 is a lot. 13 is a lot. So we can just do 3 for now, which are actually like the most commonest. Because like I said, the disease it's quite rare, but then it doesn't mean that it's not there. It is there.
It is there.
Yeah. So let's talk about the different types.
For the types, we have 2 major types. That is hemophilia A and hemophilia B.
Okay.
Hemophilia A results from a defect in factor number 8. We said there are 13 factors. So when your X chromosome gene has a defect that defect in the X chromosome that instructs the body to produce factor number 8, then you will get hemophilia A.
Okay.
You get it? And now, hemophilia B occurs when the defect is on factor number 9.
Yeah.
Yes. So if your X chromosome has a defect that instructs your body to produce factor number 9, clotting factor, then you will get hemophilia B. And then there is hemophilia C, which is not common.
Okay.
That is the defect on factor number 11.
Okay.
Yes.
Why? Okay. So, fine. So there are 13 factors, right?
Yes.
And then 8, 9, and 11 are
8,
somewhat...
especially 8 and 9.
And 9.
Yes.
Yeah.
8 and 9. And you see, the one that is factor number 11, why it's not common, it is not sex-linked. It is not sex-linked.
Okay.
It is what we call autosomal.
Yeah.
It is not sex-linked because these two are sex-linked.
Yeah.
They appear on the X chromosome. you see. But for this other one, it is common in equal proportion in male and female.
And female.
Because
Okay.
it is not on the sex gene.
Yeah.
It is on the autosomal gene.
Okay.
So that is why it is interesting we are talking about factor number 8.
8 and 9.
And 9.
Okay.
Yes.
So does that mean that, let's say, if someone lacks what? Let's say factor number 5 or 10, you know, or even
10.
13.
Yeah.
Yeah. So does it mean that, again, they'll still suffer from hemophilia? Or
basically,
not?
they could have bleeding tendency,
Okay,
but this bleeding tendency, actually what I'll say is they are outweighed by the fact that you have intact factor number 8 and 9.
Okay.
Because if we don't have time, but I think when next time we'll have time and now discuss the whole process of clotting, what happens, because we have intrinsic and extrinsic factors that comes into play. And that is where these factors are involved. Because apart from, you know, intrinsic and extrinsic, it's like inside and outside.
Yeah.
Yeah. So so when those factors come into place, and that whole cascade, it should be a whole topic. Then people will understand why factor number 8 and 9 and maybe 11.
Yeah.
Yes.
Okay. Okay. Makes sense, because these things can be complicated. So we're trying to make it as
simple as possible.
Yeah, so that we all understand. Okay, so between the A, B, okay, you said C, it's not
it's less
common,
and it's not very severe.
And not very severe.
It's not severe. People don't suffer severity with it.
Okay.
Actually, they have manageable symptoms.
Okay.
Yeah. Some even will not know they have it.
Will not even know that they have the condition.
Yeah, exactly.
Okay, then. And then, so between A and B, which one is like more common of the two?
Basically,
or they're more the same?
Basically, it's hemophilia type A.
Type A, okay.
It is more common than hemophilia type B.
Okay.
Yes.
And then for some like other conditions, and I'm pretty sure of the conditions that we have discussed here with you, you'd find that some of them are more common in like Black Americans as compared to, or blacks, if I can say, as compared to, you know, Asians or Caucasians. So for this particular one then, is it again more on the specific race that is more affected, or it's more on sex linked?
Yes, it is more on sex linked, yes, but also
certain
races like the Asians and the blacks. I don't know why.
Yeah,
I don't
most
know.
of the time we ask why, and the doctors say we don't know.
I don't know. Even me, I don't know why actually the Asians. I don't know whether it's because maybe many studies have been done on them. I don't know. I'm not sure.
Okay.
Yes.
All right. Let's take a break on that note so that we internalize all that we've learned on the first part, and then we'll come back with, again, some of the risk factors for the same, some of the causes, because like you said, yes, this genetics, which play a major role, but does it mean it's the only cause for the same? And then we can talk about diagnosis and treatment as well. But if you have any other question in relation to today's topic, then again, feel free to engage with us on 40920. We look forward to hear from you. But for now, let's take a very short break. We'll be right back with more on hemophilia. Stay with us. All right, welcome back. Glad you're still with us. This is My Doctor. And just in case you're tuning in right now, today we are discussing a topic that I feel it's very, very important for all of us to just have an understanding about, and that is on hemophilia. And like we said, it's not a very common condition, but that does not mean that it doesn't happen or it doesn't occur, because there's some people who are actually living with the condition in as much as it is rare. So it's important for all of us to just have an understanding about hemophilia. And like we said, if you have any question, feel free. I mean, our lines are open, so you can engage with us on our SMS line, that is 40920. We look forward to hear from you as far as hemophilia is concerned. Dr. Njenga is here to answer all your questions, okay? As he is giving us the insights we need to have as far as hemophilia is concerned. So, Doc, before we went for break, of course, that aspect of then the causes. And, you know, we talked about an aspect of genetics playing a huge, a big role, you know, in hemophilia, and how, again, it is transferred, and especially in families. But then again, just in case someone is tuning in right now and thinking, okay, now I missed that, I don't understand what's happening. Can we just go back to it very briefly, and then we'll talk about the other risk factors as well?
Okay, thank you so much. We say that hemophilia is actually passed, is a disorder that is inherited, meaning it is passed most of the time genetically.
Okay.
And we said that a female has 2 X chromosomes.
Okay. Okay.
And a male has 1 X chromosome and 1 Y chromosome.
Yeah.
These are sex-linked chromosomes. And we say that the defect, for you to have hemophilia, a defect has to be on the X chromosome. That is why it is called X-linked or X-linked chromosome.
Okay, we have a picture of the same so that it's easier for people to understand.
Yes.
So that we can see. All right, there we go. There we have on the screen. So the blue one is the man. Okay.
The blue one is the man.
Okay.
And
then the other color we can
is
quite
the woman.
Yes. So the woman. And then they are affected. So the blue is the dad who's affected, right?
Okay, the
man
dad
who is affected.
The dad is affected, and I said since the dad has X and Y chromosome, he will pass the defect to the daughters. Why? Because the daughters will take the X chromosome from the dad.
True.
And another X chromosome from the mother.
Okay.
And you see the mother is not affected. That is an affected mother. So if you look at that picture and that cross-link that goes there, it will tell you that the father who is affected, when he gives the X chromosome and the mother gives the X chromosome,
yeah.
because he only have 1 X chromosome. So if they have 4 kids, 2 daughters will be carriers.
Okay.
Will be carriers because 1 X chromosome from the mother does not have the defect.
The defect, true.
True. But now the dad will not be able to pass this trait or disorder to the sons.
To the sons, yeah.
Because the mother is the one that gives the X chromosome,
and then the
dad gives the Y chromosome. And the Y chromosome does not carry the gene that is responsible for the production of the clotting factors.
Okay. Okay.
Now, if we go to the next diagram, where we have illustration, where we have the unaffected father,
Okay.
and the mother is a carrier. You can see that.
Yeah.
So the dad gives the X chromosome, which is not affected, it does not have the defect. So, and the mother gives, can give either the X chromosome that has the defect or the one without the defect.
Yes.
And the ones that are affected here, you can see, because there is a chance that the son will get the X chromosome from the mother.
From the mother, yes. The one that is defected, right?
The one that is defected,
Okay.
one son. And the dad will give the Y chromosome.
Okay.
So one son will be affected.
Yeah.
And then there is a chance that one daughter will be a carrier because one of the X chromosomes from the mother will have to pair with the normal X chromosome from the dad. So in that whole scenario, we have seen that when the woman is affected, she will pass the trait to the son and also the same to the daughter, but the daughter will become a carrier, and the son will have hemophilia.
Okay.
Yes.
And then probably the other son, if they
Are
have
unaffected.
other children,
Yes.
one might be affected, one might not.
Yes.
For the daughter, one will be a carrier, one might not be.
Yeah.
One might not be a carrier. Very interesting.
But
That
the
sums
men,
up-
there is
yeah.
no carrier for men.
There's no carrier for men.
Yeah.
Yeah, as you can see actually from both the diagrams,
Yeah.
there's no carrier for
And
men.
the
It's either you're affected or
yes.
you're not affected. Okay.
And the reason we say there is no carrier for men, because you have only one X chromosome. But for women, they have 2.
Two. Yeah.
So when one is affected, the other one still produces clotting factors. So it kinds of inactivates the one that is
defected.
Yeah.
I like that. Very interesting. Okay. All right. And I think from this diagram, it explains so many things. Remember, I mean, there's so many other conditions that people say.
Yeah.
So we're like, let's say 5 children, okay? Maybe 1 or 2 have the condition, and then the 3 do not.
Others,
or one is a carrier.
Even all
of them actually don't have.
Because you don't know the probability which will match with which.
Yes. It's so true. Okay, that's very interesting. Okay, then. So in terms of, I think that sounds a lot. Basically, most of the things that we talked about in the first session. So now you have a better understanding of how that comes about. But does it mean that then it's only genetics that, again, can cause hemophilia?
No, no, no.
Okay.
30% of hemophilia, we have always known they also are acquired, whereby you were born without hemophilia, but in the process, your genes might mutate. Like for male, I'm talking about male. Yeah, the genes might mutate on the X chromosome. The gene factor number 7 that produces factor number 7, or the gene that is responsible for not 7, number 8, and the gene factor that is responsible for the production of clotting factor number 9
as well.
They can mutate because of some conditions like autoimmunity. We have talked about here autoimmune, whereby your system produces antibodies against
your own system.
So it will produce antibodies against the X chromosome, the gene that is responsible for the production of clotting factors. Another condition that would bring acquired hemophilia is pregnancy, even pregnancy. Yeah. And also conditions like cancers, they can alter the body or the gene makeup, the chromosomal gene makeup, and also conditions like multiple sclerosis. Those are some of the conditions that would actually bring about acquired hemophilia, that you were not born with hemophilia, but at the age of maybe 30, 20-something, you get hemophilia. Yes, and you start wondering how. And there is no family history
of the same.
Yes.
That's it. Okay. So then, so could we say, maybe of the cases that we have probably in the country, although again, it's very rare.
Yes.
But could we say that most of these cases are more on the acquired side as compared to genetics?
I would say it is like 50-50 because, see, we are improving on diagnosis. Before we were not good on diagnosis, but as we advance, we are making a good progress in diagnosis. Because basically, if a child is born within 2 years, on proper diagnosis, up to 2 years, 1 to 2 years, you should be able to diagnose hemophilia. But we said also, those with mild symptoms, and we are going to see here, might show the signs and symptoms later in life, in adulthood.
Yes. So it might be difficult to pick again earlier.
Also
they don't develop the symptoms easily. And for pregnancy then, because again, someone will be like, hey, but I'm pregnant right now. Doesn't mean I'm going to get hemophilia. So are there like triggers for this, I mean, especially during pregnancy, that might end up causing hemophilia? And will that affect the baby in that the baby will have hemophilia when they're born?
Exactly.
Okay.
For pregnancy, if now you don't have a family history, you see, if you don't have a family history, either from both sides, then, pregnancy is a very complicated thing. It might bring about the autoimmunity on itself, destroying, and also in the process of mutation of the genes, that process can be hampered, or it goes, it doesn't follow the right system or program, and then the gene mutates in another way.
Oh wow! Okay.
In the process of formation of the fetus, the genes that are responsible could mutate there. You don't have a history.
Yeah.
The dad doesn't have a history. You are not a carrier. The dad is not an affected person. But in the process of mutation of the X chromosome gene,
yeah.
then
The child might end up
yes,
again.
yeah,
getting
if
the
there
same.
is some problem in the mutation, yeah.
Whew, okay, but it doesn't mean that everybody gets it. Because
No,
like we
no,
said,
no,
this is rare, and even the one, especially for the acquired again, they're
Yeah.
all rare.
They are all rare,
No
very
cause
rare.
for alarm.
Yeah,
No cause for alarm. Okay,
Yes.
then. So for and I think that is why we advise, especially in pregnancy, just maintain a good diet. Because then
Exactly.
that will boost your immune system
Yes.
and your, you know, and it's so that, again, the body does not fight itself and then destroys the good cells, which will help prevent other diseases. Now, so for the symptoms, how do I know that I have hemophilia? Do I have to bleed? Maybe, and then it is like, it doesn't stop for someone
Yeah.
to say, but wait, this person has hemophilia.
Yeah.
Or are there other symptoms that probably are there that we should look out for?
There are various symptoms. Let me start with childhood.
Okay.
For children who have hemophilia, you know, when they start walking, crawling, and walking and standing up,
Yeah.
you would find they get bruises so easily. You see, normally kids crawl,
Yeah.
and you don't have issues with that. But with kids with hemophilia, you'll be able to pick because, number one, they will get bruises
Very
easily,
yeah.
and continuous bruising affecting the joints will bring swelling to the joints, the knee joints, the elbow joints. And so for kids, those are the things you look at. Maybe even kids playing, they get cuts. So you would notice this clotting is taking quite a long
while,
time.
yeah.
Maybe even, you know, the first aid people do at home, tying a piece of
Yeah.
cloth, you know, or a bandage or whatever. Then you find like you have tied and the bleeding is not stopping. And maybe it
Yeah.
was a small cut. So that is one of the symptoms.
Okay.
Or for those people who miss or they have mild or moderate symptoms,
yeah.
mostly mild, and they are in adulthood, probably you would pick the symptoms when they get trauma,
All right.
when they get cuts, because now bleeding will not
Did
stop.
not stop, yeah.
When they go for procedures, like dental procedures, extraction,
bleeding and
you
it
see,
doesn't stop.
you just extracted a tooth and the bleeding won't stop. You are going
Yeah.
back to the dentist the following day. You say, I've bled the whole night. And you see a clot is supposed to form.
It is, yeah.
Most of the boys, because we said it's more in males, you would diagnose them when you are doing circumcision. You know, there are people who do circumcision
Yeah.
early,
Yeah, yeah.
and some who do. Like, you know,
Probably
African
later.
culture, most of them do.
Around age 5, 10,
yes.
there.
Going forward, even 10 years, 14 years, that's when you're doing circumcision. Then post-circumcision, you realize there was no
person still-
clotting.
yeah.
The bleeding, the bleeders are not, they're not, even when you tie the bleeders, the bleeding does not stop.
It doesn't stop, okay.
Yeah. So these are the symptoms. Those people who bleed internally, for example, you have had a bleeding in the brain, now you will get prolonged severe headaches, vomiting, seizures, and epileptic fits. Some will bleed in the gums.
The same people who bleed when they brush their teeth.
Yeah.
And this is not like related to like the gum disease or
Yes.
anything. They just
Yeah.
bleed.
They just
you know?
bleed. You should
Yeah.
find out, why am I
Why?
bleeding? Yeah. Some people just have nose bleeding from nowhere, spontaneous nose bleeding, frequent nose bleedings.
That should be
Yes.
an alarm.
Now, you see, if you rule out all other causes like
Yeah.
hypertension, issues with ENT, now you should always go a
Yeah.
mile further and say, could it be something else? A clotting, issues with clotting in my blood, you see?
Yeah.
Yeah.
Okay.
You see, some will bleed in the GIT. They could vomit blood. Some would cough blood if the bleeding is in the respiratory system. Some would have blood in urine when it is in the urinary genitourinary tract, and some would also have also in the GIT will have what we call melena, that is bleeding that has occurred in the upper GIT, but when you going to pass the stool, the stool content is black, or you even have frank red bleeding parectal. So these are some of the symptoms, and sometimes for ladies, because we say they don't suffer, but the symptoms could sometimes you could have moderate, such that when you get to your menstrual periods, you find you having exaggerated menstrual periods. It's always good to find out why. Yeah. If I've tried the courses, I've been told I'm okay, it's always good to try to find out. Yeah. So those are some of the symptoms. And if you bleed a lot, you're sure that you probably would be also anemic. Isn't it?
Yeah, because you're losing a lot of blood.
Yes, you're losing a lot of blood every now and then. Like you've heard of cases, I usually nosebleed. Yeah. Every other time I
when you talk about nose bleeding, I was like, wait.
Yes.
Nose bleeding as well? Because we hear this a lot. Yeah. Like, it's common for me to nosebleed, but really no, that should be, it should be checked.
Yes. So it's always good if a symptom has been there for a long time, just go have a checkup, and talk to your doctor. Let them evaluate. Yeah.
And let them tell you are okay.
Exactly. You don't have this thing.
Okay.
Exactly.
And then again, so for menses, for ladies, is it more on then the duration of time? Because we know it's about 4 to 5 or 6 or some people 7 days, and that's it. But for the one with hemophilia, does it then go past?
It is heavy and prolonged. 1 week, 10 days, 14 days. You know. That's messy.
Please go get checked for the ladies, because we hear this a lot. Some people would say, mine went for like 2 weeks.
And they're comfortable.
Normal. Some people think it's normal. Like it's not. Please go and get checked. Okay then. So in terms of, and especially for those people with like very mild symptoms, do they experience like pain? Is there like an aspect of pain? And then for headaches, because headaches like comes with so many things, and we get scared when something, for instance, hemophilia, and like you said, especially if it's internal bleeding in the brain, you'd feel headaches, dizziness. So is it like throbbing? Is it constant? Is it on and off? And is there specific parts of the head that you feel?
Actually, it is prolonged. It is continuous.
Okay.
Most of the time, it's not going to be on and off.
Yeah.
It is long-standing. This is a headache. Even when you take a painkiller,
it doesn't go away.
It doesn't go away. And most of the time, you'll find people will take the wrong painkillers that will worsen even the condition.
Situation. It's true.
The aspirin-based painkillers, because they believe like it works instantly. I've heard people using a drug called Maramoja. It's instantaneous, but they forget it has a very high dose of aspirin. And if you have, if you, for instance, you've got hemophilia, you will you'll even make the condition worse. So, so the headache here is most of the time prolonged, long-standing, and occipital. It could be occipital.
Okay, all right.
And you feel heaviness, vomiting, and nausea.
As well.
Because of maybe intracranial hemorrhage and all that. Yes.
All right, but it's because you see, and especially when you say people who take painkillers, some really with very high dose of aspirin, we do that a lot. We tend to self-medicate a lot.
Yes.
And like Dr. Njenga says, you might end up making the condition worse. So please just go to a hospital and let the doctors do their job, all right? And rule out anything. Okay then, because I can see our time is far much spent. So fine. All the symptoms, probably one might notice 1 or 2 or 3 of the symptoms that we've talked about and go to a hospital. So what is like the diagnosis process? Like, is it more clinical? Is it more lab-based? What happens during the diagnosis, and how long does it take?
Okay, a diagnosis is both clinical and the symptoms, that is clinical part, and the laboratory.
Okay.
Because you have to confirm now. I cannot just take your symptoms and just say now, you've got hemophilia. No. When you have a family history, and that is where we also talk about people who are at risk, are those with the family history of the disorder in the family.
Okay.
Either ways from both parents or even in the extended family. You never know.
You never know.
The mother could have inherited it and she's a carrier. So if there is a family history of the same, you are at a high risk.
Okay.
So also when it comes to diagnosis, we want to take history and we want to find out, do you have a family history of the disorder? Is there anybody in your family? It could have not been diagnosed because of poor diagnosis, but maybe somebody will tell you, my grandmother used to bleed a lot. Maybe you should take, or my grandfather used to nosebleed a lot. You see, you just take that history as a positive history, then you will combine with the symptoms, swellings, easy bruising, prolonged time in clotting, those who get continuous bleeding in the joints, they get swellings, even tend to get arthritis and all that because of continuous swellings in the joints. So you take that history.
Okay.
You take history even systematically, the way we've said. Is there vomiting of blood? Is there coughing of blood? Is there urine in blood? Is there not blood in urine?
In urine, yes.
Is there blood in stool? And all that. You just take that. Do you have a headache that is long-standing? You just take the history, and then now you will do the laboratory workup, where we do basic tests like a full blood count. That is just basic. We do other. We also analyze. We want to analyze your factors, clotting factors. We can take the clotting factor assays and check on factor number 8, factor number 9,
or 11,
or factor number 11, whether it is present. At the same time, we can do also what we call activated it is APTT. The name has just gone.
And it's quite complicated, so
yes,
it's okay.
and prothrombing time.
Yeah.
This actually check on the how long does it take for you to clot? How long does it take?
Okay.
And then based on the systems and the symptoms that you could prevent with, we also can do other tests, including CT scans for the head.
Oh yeah, yes.
Because maybe you come with severe headaches, we just think you have had a hemorrhage. We can do CT scans of the head, or any other organ that we think, of the lungs, of the abdomen. We can do ultrasounds, even, and also CT scans and MRIs for the joints.
For the joints as well. Yeah.
Just to check whether the joints have been affected
or not.
And what is the extent of that they have been affected. So we can do many tests.
Intense diagnostic process. Okay then. And so fine, all these tests done, and then you come up with a conclusion that this person has hemophilia. What are some of the treatment options? And could you answer this very briefly?
Very briefly.
Time is
so the treatment options that we have, it depends on the mild and severe and moderate. For the mild, you know, you just give people what we call fibrinolytics. Those will help in clotting process, especially people with nosebleeds and bleeding gums or mucosal bleeding, and those people with severe bleeding condition or severe hemophilia, we replace the factors. We do what we call factor replacement. Factor number 8 replacement, factor number 9 replacement, and we use whole blood. And then the laboratory people will be able to extract the factors that we need. Or otherwise, we can use laboratory prepared clotting factors, what we call recombinants. We use them and then we give you intravenously. And then that is one of the mode of treatment. And also, sometimes we give some hormone we call desmopressin. This actually activates your body to produce more clotting factors, like clotting number 8, clotting number 9. So we actually are able to manage hemophilia that way. And that one has helped us because now, you see, even the prognosis, because of this treatment, has been improved.
Improved,
Yeah.
okay. So then does it mean, so someone can be cured completely?
No, 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 no.
Okay.
We
Or
don't
it's just
cure.
to
It's just
manage.
manage until the day.
Okay.
Yeah, we just manage
So you
this.
have to be on the medication.
Yes, and on follow-up,
Month-long.
on clinics,
Yeah.
you have to see your doctor. If it's a hematologist,
Yeah.
you just see them, and then you will be managed.
Okay.
It's
All
not
right.
like long before. Actually, the life expectancy for the people with hemophilia is only 10 years less than
Oh.
the normal person
Oh,
with
that's
improved
nice. That's nice.
treatments.
Yeah,
Yeah.
that's nice. Prognosis is good.
Yeah.
All right then. So in general, and as we finish and taking your parting shot, as far as then hemophilia is concerned, because it's more genetic,
Yes.
so really for that there's nothing much you can do as far as prevention. But for more acquired, or you can. Is there something you can do? Are there tests that people can do? You know how they say there's some tests you can do before either marriage or before
Maybe,
you decide to
yeah,
get
there are
kids?
tests before
You can do the
marriage, before
tests.
pregnancy. You can do.
Okay.
You can do assays. Tissues are taken from your samples are taken from your tissues and blood, and they are taken to the lab and they are examined for the mutation, if there is any gene mutation on the X chromosome, you see.
Okay.
So if there is, you know, you could be advised by a counselor or whoever is seeing you, the doctor. That is the precaution.
Okay.
That also is a prevention.
But it's expensive, right?
It is very expensive. Actually, they are very
Okay.
expensive.
Yeah, but for the acquired,
For the acquired,
you
we can prevent,
prevent.
yeah. And also,
Okay. All
yes.
right. So, Dr. Njenga, we have to say goodbye on that
Thank
note.
you.
Time really flies by,
Really?
but thank you. Thank you so much for coming by. Really, really appreciate your time and helping us understand more on hemophilia. Now we have a better, and I have a better understanding, honestly, of hemophilia, because I was reading through, trying to understand some of these terms, you know, how complicated they can
Yes.
be sometimes, but it's easier now. So I believe that you have a better understanding as far as hemophilia is concerned. And on that note, we have to say goodbye. My name is Winnie Lubembe. On behalf of an amazing, amazing team who put together this show, we wish you a lovely day ahead. And we cannot overemphasize the fact that we need to be very careful, very cautious, and very observe the directives, really, as far as COVID-19 is concerned, so that together we protect ourselves and our loved ones and the people around us from contracting the disease. So keep safe, please stay safe, and God bless. We'll see you on another episode of My Doctor. But for now, it's a goodbye and see you soon.